Hi guys, welcome again to your own YouTube channel Ask Your Gynaecologist. I'm Dr. Sonal PARIHAR. Well, what is today's topic? Today's topic is a very simple thing that you all know, that is tubal ligation. Now, tubal ligation you all have requested, many of you have requested, you have been asking different questions, so I thought it's a very simple topic. But then again, there are many things which I think are simple but are not simple for you, so you have a lot of queries. So before I start with the query, let me just thank you all for the tremendous response the channel has received from you all. We are already a family of 8.5 lakhs and we are soon going to become 1 million. So thank you very much. There are 3 ways to contact me to get prescription or to have a second opinion from me. One is DocWise app, which is an application which you download from the mobile's Play Store, and then you insert my PIN. So you get connected with me on the mobile. You get 2 days to chat with me. Calling option is there. I can call you on your Indian mobile number, but for the last 3-4 months there is some problem in the network because of which I cannot call. There are some technical errors. So I can send you voice message, you can send me voice message, I can send you the prescription or give you second opinion by writing. Now the second way to contact me or to get a prescription from me, not really, you can get a prescription from me if you come to the hospital. Let's take that option first. Now coming to the hospital, get an appointment for my secretary, make sure I'm in the city, and that is the best way to consult a doctor. You come to the hospital, I can check your reports, I can check you physically, and that will be the best way to interact with me. Third way is the super chat option, which I use, which you can use whenever I go live on this channel and on the other channel, Dr. Sonal's Answers. You can use your credit card or debit card and you can pay, and then your question flashes on the screen and you get the answer there and then. But no prescriptions please, no discussion about the drugs when I am going live. Okay, now when we talk about tubal ligation, first of all the question that comes to our mind is, what exactly is tubal ligation? What do you do? Well, there are 2 fallopian tubes in a lady. Now the function of these 2 tubes is to catch the egg from both the ovaries and propel it, just push it inside the uterus so that it gets fertilized by the sperm which comes from the vagina, and then the baby goes and sits inside the uterus. Now tubal ligation can be done in 2 ways. Either we block the tube with something or we cut the tube. We cut the tube and remove it, or we just cut the tube and tie both the ends. So there are different ways in which we can do it. Let us discuss the different ways. Now the occlusion methods in which we just occlude the tube are: number 1, fallope ring, which you can see in the photo. This is outdated. It is no more used in the European countries because the failure rate is very high. In India, we are still using it, especially in the camps conducted by the government, because it is very cheap. What we do is we just hold the tube and we make a loop of the tube, and then the ring goes on it. So the ring goes on the loop, and it is, although it is safe, it does not cause any problem, but it can slip. Once it slips, the ring goes inside the tummy, it just lies somewhere, it doesn't do anything, and the tube opens, and the tube has opened, so obviously the failure rate is very high. That is why it has been banned. Second thing is the clip. Just like you use your clips for drying your clothes when you put them in the sun on the wire, this is how the Filshie clips have come in. These are called Filshie clips. They're cheap. They're not as cheap as fallope ring. They're actually costly, and they're good because the failure rate is very less. The occlusion is very good. Sometimes precautionarily we put 2 clips on both the fallopian tubes. But what is the side effect? Well, they might just migrate. They might just tear the tube because they're heavy, and they might just go and rest inside the omentum or the bowel or the other structures in the tummy, and that can cause necrosis, it can cause infection. Again, very rare, but this can happen. Okay, third way is, which many doctors do, they kind of hold the tube in the center, cut it, and then they cauterize, that is, they heat both the parts. So they damage the tips of both the parts, thinking that this will not let the tube join in. Well, it might work, but sometimes the failure is there. Failure can happen. It is nature. Sometimes that cauterized tissue, it just grows out, and it just falls off, and the healthy tissue just grows in and they join together. Some doctors, they tend to remove the central part. They cut the tube in 2, remove the central part, and then cauterize the other 2 ends, or tie the other 2 ends, so that in no way that it can migrate and join. But again, you never know. Okay, failure rate is always there. Now my favorite way, which I normally use when I do a mini laparotomy, is make a loop of the tube, tie it at two portions. That is called the Pomeroy's technique. You just tie the tube here, and then we cut the loop. So when we cut the loop after 1 month, when both the threads are dissolved, this tube goes this apart because that central part is removed, and then once it opens up, this opens up here and this opens up here. So this is this much gap. Thankfully none of my ligations have failed so far, but it can, because it is obviously written in the books, it is documented in the books that almost 0.1% failure is there. So I would say if it fails, it is not the doctor's fault. Yes, it depends upon the kind of procedure the doctor has done, and depending upon what type of patient you are and in which time period it was done, which we'll be discussing now. These are all the factors which decide the failure rate. Okay, now coming to the question when it should be done. You must have noticed that if you go to the doctor for ligation, a doctor will tell you that you have to come in the first 7 to 10 days of your period. If you go in the mid-cycle, the doctor refuses to do it and you get angry. Oh my God, I took leave from my office, I can't come back again, please do it, please do it. Don't get into that, because the doctor is right. What happens in patients who are having short cycles, even on the 10th day they might ovulate. Normally the 28 days cycle, the ovulation happens at around 14th 15th day, but what happens if you have a cycle of 25 days or 22 days? You might ovulate on the 10th day, right? Now if you are ovulating and the tube has already caught the egg is already there in the tube, and suppose the sperm has already gone near it and the fertilization has happened, you don't know you are pregnant, and the doctor then ties the tube because you have gone in that particular phase after ovulation. The doctor ties the tube, so there is no way that this zygote, this fertilized egg, it can enter the uterus. So it will just implant there in the tube, and then you will end up in an ectopic pregnancy, which is life-threatening, you know that. Okay, now what happens if the zygote, the fertilized egg has already traveled, it is almost going to enter the uterus, and then the doctor ties the tube? So what will happen? You will go and sue the doctor. You will tell the doctor you are at fault because I was not pregnant at that time, and just a couple of days after your operation I have become pregnant. So again, it is not doctor's fault. It was his fault that he agreed to you, that he did the operation at the wrong time. But it was basically a pregnancy which you have already conceived. But just because you did not miss your period, you did not do a pregnancy test, you didn't know that. So after a couple of days, you will miss your period and you will say that it was doctor's fault. So please don't put yourself at risk. Listen to the doctor. If the doctor doesn't tell you that, then it is his fault. But if the doctor is telling you and you're not listening, then it is totally your fault. Okay, so it has to be done in the first 7 days of the menstrual cycle. Day 1 to day 7 are safe. Nobody ovulates in those 7 days. Okay, that is the best time to get it done. Now the other times to get it done is immediately after cesarean, during cesarean, or immediately after delivery. If it is done during cesarean, it is a very simple pomeroy's technique which I just told you, just tying the tube in the way doctor likes it, tying it, cutting it, cauterizing it, whatever. After delivery, because you have just delivered today, the uterus is still here, it is still your umbilicus, so obviously you cannot get a low incision near your hairline, but you are adamant that you want the surgery, and sometimes doctors agree because that is the time period when you need rest, so you think both the things can be combined. So we will not do it on the same day. Suppose you deliver today, we will do it 24 hours later, so that the edema, the vascularity comes down, the uterus goes down slightly, and then you get a cut quite high in your tummy, almost near the navel or just below it, because the uterus is quite high. But it is not a laparoscopic surgery, it is an open surgery, a mini laparotomy. A small incision is given and the tubes are tied routinely, as I told you, just like tying it, cutting it, or cauterizing it. Okay, so these are the ways in which we do it. Now, how big is the operation? It is not a major operation. You can be put to sleep if the laparoscope is inserted. It's a minimal access surgery. We are using a laparoscope for that. Then in that case, we cannot give you a spinal. We have to put you to sleep, but it's a short GA of 15-20 minutes. If at all we are opening the tummy, then you might either get a spinal, which is a needle in your spine, which you normally get during cesarean, or we might put you to sleep for say half an hour, because when we open the tummy, then it has to be closed layer by layer, so it takes slightly longer time. Okay, both the surgeries are very minor surgeries, no bowel handling, no handling of the other tissues. So within 12 to 15 hours you are ready to go home. So if we do it early in the morning, you can go home in the night, or maybe just stay for 24 hours, because within 2 to 3 hours you will be allowed to eat, to drink, because you will be fine. You will be able to walk, you will be able to go to the loo. Once you go home, rest, I would say 5 to 7 days. Within 2 days, you will feel that you feel like walking, you feel like doing your work, going to the toilet. Yes, bending will be a problem. Picking up the child in your lap will be a problem because you have got stitches in the tummy, but you can work in the kitchen. So the routine activities can be done. Within 10 days, your stitches will be cut. You can start going to your office, I can say 15-20 days after that. But yes, constant sitting for long hours might be uncomfortable. Next, coming to sexual activity, many people ask me, when can we have sex? Well, it is not a major surgery that you have to take a gap of 1 or 2 months, but people do that. I would say 15-20 days is enough for every healing. It depends upon your own conscience, your own tolerance, your own workload. So it is basically on you. Nothing will happen medically inside. If you have sex, nothing is going to break. No stitches are going to break. Okay. Next, coming to the complications. Well, the complications are many. Most common ones are, first let me tell you all the common complications which any kind of surgery will have. Anesthesia complications, infection chances, bleeding from the wound, bleeding inside, damage to the structures which are out inside the tummy, like we are just handling the tube in case somehow we handle the bowel, we kind of enter the bowel or we injure the bowel or anything else like bladder or that is quite common during surgery. Okay, any kind of surgery. Next, coming to complications pertaining to ligation. Now, because we are cutting your tube, we are handling your tube, we are going to hamper the blood supply which supplies the tube as well as the ovary because they're very near. So, if the blood supply to the ovary is hampered, you might end up having some hormonal problem, you might end up having irregular bleeding or heavy bleeding for some time, you might end up having surgical menopause, early menopause, because the ovaries, the blood supply might die. Now, it all depends how much damage has happened or what was your age at the time of ligation. Next, complication, as we just discussed, is ectopic pregnancy. Again, this is life threatening. So, if you are careful when it is done, then you can avoid ectopic. But yes, ectopic can happen even if the tubectomy, the tubal ligation was done at the right time, because if it is done at the right time and the tube is not properly occluded, there is some leakage, it is not completely closed, then the ectopic can happen because then it is kind of a damaged tube. So if the zygote, if the sperm has able to enter that blockage and it fertilizes the egg, it has no place to come inside, so it can just cause an ectopic there. So again, it is quite common. Next, coming to the other complication, endometriosis, quite common, quite common. 40 to 50% ladies have been found to have grade 1, grade 2 endometriosis after tubal ligation. Now, that's something we don't know the theory, but probably the theory of endometriosis works here, that whenever you menstruate, there is some blood which gets diverted from the fallopian tube to the abdomen. Now, if there is blockage in the fallopian tube, then obviously it will go with some spurt. Just like when there is a narrow area, the pressure is more. So with that pressure, probably it just goes inside the abdomen and endometriosis happens. So grade 1, grade 2 are quite common. Grade 3 is very uncommon. Next, coming to the complication is post-ligation syndrome. That is again just like appendicectomy causes lots of adhesions and pain, constant pain after surgery. Similarly, sometimes because of ligation, the bowel, the omentum, the ovary, they all get stuck there. Then there is some infection, some pain, some bleeding, and that causes lots of adhesions, and that becomes a post-ligation syndrome. If it is very bad, it has to be surgically removed. We have to put a laparoscope inside and remove the adhesions, whatever is sticking to that area. So that's post-ligation syndrome. Next, coming to the failure rate. Well, failure, as I said, is very less, 0.1%, but 1 out of 200 women will be seen pregnant with a proper ligation. So again, this is nature, we cannot fight nature. If it happens, you can't sue the doctor because it is already documented that it can happen, unless you prove negligence, that there was some foul play or negligence from the side of the doctor. Okay. Next question is, what if I want a reversal? Tubal ligation is supposed to be a permanent sterilization when you and your partner have completely decided that you do not want any more children. In case you want an interval contraceptive, then watch my video on contraceptive methods part 1 and part 2. In part 1, I have discussed the natural methods. In part 2, I have discussed the methods which the doctor would advise you, and you have to go to the doctor for that. Now, if you really want a permanent thing that I don't want any more children, then it is tubal ligation or vasectomy. That is your husband's vasectomy. Again, permanent sterilizations can be reversed. Sometimes mishaps happen in the family. They want more children. 25% success rate is there. That is all. That is 1 out of 4, even less depending upon what kind of surgery was done. If it was a laparoscopic ligation in which just the fallopian was inserted or the Filshie clip was applied, it is easier to open such tubes because none of the part of the tube is missing. The entire tube is inside the abdomen. It is just occluded. So we just need to freshen up the margins and rejoin them. In case it was a mini laparotomy, a Pomeroy's technique in which some part of the tube is removed, cut, cauterized, that reversal becomes difficult. We might be able to join them because as a surgeon I know I can join things, but they have to work. We cannot guarantee that because tube has lots of cilia, lots of hair inside, lots of muscular actions which kind of pulls the egg and pushes it inside the uterus like a propulsive action. So that particular action we cannot guarantee. You can just join it. So that is why the success rate is only 20 to 25%, and sometimes patients, they do get pregnant, but it ends up in an ectopic pregnancy because a tube which is reopened, rejoined, it is kind of a damaged tube. So again, it is your luck. It's not going to harm you, but yes, the success rate is very, very less. So if you really want a reversal, then you have to think, you have to talk to your doctor and respect what the doctor is telling you, right? Now, the last question is, what is safer, vasectomy, that is husband's ligation, or tubectomy? I would say vasectomy is a no scalpel technique. It does not require hospitalization. It does not even require stitches. No scalpel, no knife. Just simply the vas deferens is tied up. It just needs 2 to 3 months of use of condom because even if we have tied the tube which carries the sperms, the portion which is ahead of that blockage that we have done, it still carries lots of sperms, and that can keep on ejaculating. The male can keep on ejaculating till about, we can say, 2 to 3 months depending upon your frequency. So that is the only drawback of vasectomy. Both are equally good. Both have very low failure rate, but the morbidity is more here. The female has to undergo an operation. She has to be anesthetized. The abdomen has to be cut, and she needs hospitalization. She needs rest. So obviously this is better when it comes to recovery. The time period is less, the pain is less, the hospitalization is not there. So yes, in the comparison, this vasectomy is better than tubectomy. Okay guys, so in case you have any more questions, you can always inbox me. I'll be ready to answer them in my live session, and take care. Bye bye. I'll be back again with a new video. Bye bye.